My name is Thejini, and the topic of my presentation is Out of Touch with Reality, the Empower ZN study, and it stands for Exploring Mechanisms of Psychosis with Virtual Reality in KwaZulu-Natal. I have been supported in this research by Prof. Stefan Duplessis from Stellenbosch University. My supervisor is Prof. Teliza, and my co-supervisor is Prof. Failing. So I'd just like to start off with a quote by Eckhart Tolle that says that acknowledging the good that you already have in your life is the foundation for all abundance. And I would like to express my gratitude to the village of individuals and institutions that have made this research possible. An overview of what I will be talking about includes a background and rationale to the study, methodology, some preliminary results, a discussion, and an ensuing conclusion. So globally, the prevalence of psychotic disorders approximates 1.5 to 3.5%. Their devastating impact, however, is felt not only by individuals, but by their families, communities, and society at large. Psychosis, as we all may know, is impacted upon by a myriad of factors which may cause or exacerbate it. It thus stands to reason that research in this area is important to advance public health interventions from treatment, rehabilitative, and preventative perspectives. So with that in mind, virtual reality, or VR, is an innovative and unique approach in order to perform controlled, immersive, and ecologically valid assessments in this area. Over 3 decades of research in high-income countries have shown that individuals with a higher psychosis liability are more likely to experience more paranoia when faced with neutral virtual environments, environments with an increasing level of perceptual stimuli, instances where there are an increasing number of stresses, as well as where there is negative evaluation compared to healthy controls. Pre-existing subclinical paranoia may mediate this sensitivity in individuals with a higher psychosis liability. In low to middle income countries, there is a paucity of research in this area, and this could largely be due to the resource-constrained settings that we find ourselves in, despite the fact that it has shown to be safe for use in individuals with psychotic disorders or high psychosis liability. So with this in mind, I've laid out the aim and objectives of the study, and the main aim was to investigate environmental mechanisms of psychotic disorders utilizing virtual environments. The objectives are threefold. The first is to ascertain whether virtual environments, which are social or those that elicit an implicit fear response, are actually able to elicit stress, paranoid ideation, or momentary mental states. The second is to assess whether the psychotic or stress response is higher in those with a higher psychosis liability, those with more social adversity, or those with more psychiatric symptoms. And the third one is to look at the experiences of participants in these virtual environments. So in terms of the methodology, this project was undertaken from the 6th of July to the 13th of December last year. The study design was a case control, single session, mixed methods experimental study, which obtained ethical approval prior to the onset of data collection. The participants were obtained from the main psychosis mapping in KwaZulu-Natal, or SciMap ZN study, which was funded by the South African Medical Research Council. In terms of the inclusion and exclusion criteria for cases and controls, so the inclusion criteria were individuals who were 18 to 64 years of age, those who were resident in the catchment area, which was the Msunduzi municipality, for a period of 6 months or more. In the case of cases, it was individuals with a diagnosed psychotic disorder as part of the incidence cases from the main study. And the exclusion criteria were individuals who had transient symptoms due to intoxication. So the same applies for controls, but the difference being that having a diagnosis of a psychotic disorder was obviously an exclusion criteria. So participants were telephonically contacted, and you can see they underlined Pietermaritzburg. That was the area that the study took place. And once telephonically contacted, they then came to the site. Written informed consent was obtained, and each participant was reimbursed 250 Rand. So just an overview of the instruments that were used. There is some baseline SIMAP-ZN data that is being used for the study. Before experiments, a whole host of questionnaires were administered, and I will allude to this during the preliminary results section. During experiments, we measured objective measure of physiological response known as the galvanic skin response or electrodermal activity, as well as recording of the audiovisual part of the experiments. Between experiments, we looked at scales that looked at state social paranoia, as well as momentary mental states. And lastly, we looked at what the experience was in that environment. This was also done after experiments as well. And after experiments, we looked at how immersed or present individuals were in that environment, as well as whether there was any simulator sickness, which you can get in virtual reality. So in terms of the methodology, experiments 1, 2, and 3 were experiments or environments that were from the Netherlands. The first one was done in an office environment, which was a neutral environment, and this was to acclimatize participants to the virtual reality experience, particularly for those who had never had that before. Experiments 2 and 3 were done in a bar. The second experiment was when individuals had to order a drink at a bar, and there was increasing insinuations of an unsafe environment. Experiment 3 then added the element of social evaluation, where people were questioned as to their ability to sort of fit into a netball or a soccer club. Experiment 4 was proudly South African, and it was developed by Prof. Du Plessis in conjunction with his colleagues at Stellenbosch University. And this was a township environment based off Google satellite images. And the aim of this exposure was to elicit an implicit fear response, whereby it was a free-roaming experiment, meaning that individuals walk through these green lights as seen on the slides. They did so by using a joystick and walking on the spot. And as they entered each green light, something subtle would happen in the environment. For example, dimming of the lighting, a bit of fog, perhaps some noises, or a vague figure of an individual in the distance. And I'm very thankful to the research assistants who were instrumental in the data collection and good quality of the data collection as well. So in terms of statistical analysis, the p-value was set at less than 0.05. Data has been input into SPSS version 29, and I'm just going to be talking a bit about descriptive and inferential statistics that have been done. I've yet to do any regression models, look at the recordings, as well as the thematic analysis. So there's a lot on these slides, but I'm just going to summarize. So most participants, you'll see the green highlights are where the percentage is the highest in comparison to the other sort of subcategories. So most participants, firstly, we were able to enroll 74 controls and 73 cases during that time period. A majority of participants were male. They were aged 21 to 40, indigenous South African, first language isiZulu speaking, born in a rural area but currently residing in a township, with the highest level of education being a secondary level of education. And they were currently unemployed, single, with quite an appalling household income of less than 7,000 Rand per annum. So this is part of the SIMAP-ZN data, and you can see that it's incomplete, so there still needs to be some data management that occurs here, because I only analyzed about 47 cases, because the rest I still have to go through the actual files. The statistically significant findings here are that cases scored higher than controls in aspects of emotional abuse, as well as sexual abuse, with the respective p-values stated there. In terms of baseline measures, looking at paranoia, social anxiety, perceived stress, brief core schemas, the momentary mental states, everyday discrimination, as well as simulator sickness, there were no statistically significant differences between cases and controls. In terms of the sensory gating, however, there was a difference in terms of perceptual modulation, whereby cases did score statistically significantly higher than controls. So onto the bit more interesting part. So this is the state social paranoia scale that was administered after each of the experiments. And you can see at time point 1, so each of the time points represents when the scale was administered after that experiment. So after experiment 1 would be time point 1. So you can see at the start point, the scores are similar and then it sort of fluctuates. But of interest is that if you look at time point 4, which is after exposure to the, sorry? They're not showing. Thanks, it was showing you. Thanks. Okay, so of interest, at time point 4, after exposure to the South African environment, which was free roaming, you can see that the score of the controls are in fact much higher than that of the cases. And this was statistically significant between the cases and controls. But also if you look at time points 1, 2, and 3 of the controls compared to time point 4. And this is further underscored if you look at these two this slide. If you look at distress and anxiety, and time point 1 here represents baseline. And at baseline, you can see there's quite a significant amount of distress and anxiety, which is then alleviated after exposure to the neutral environment. And again, at time point 4, after exposure to the free roaming South African environment, there are statistically significant differences in terms of the paranoia score, again with controls, which are supposedly healthy people, compared to cases scoring higher. So overall, we can see that the social demographics do differ quite significantly from high-income countries. There are some findings that appear to be the opposite of that found in high-income countries. And some of the proposed reasons include the validation and translation of scales. So these scales were translated into isiZulu, but there was no validation done on them. Also looking at cultural sensitivity in our setting, the role of trauma, because we know the intensity and severity of the trauma that we face is a bit different from that seen in the global north. And then it also begs the question as to what is paranoia, because in our setting it can be adaptive, because we have to be constantly wary of our surroundings, even in healthy controls. And then with patients or cases, they do have a blunted response in antipsychotic drugs. Some of the challenges faced was space for the VR hardware, training, no dedicated research time at that point, some technological difficulties. It was also single session and it was convenient sampling, so generalizability would be affected. And the environments were predominantly Dutch and may not be translatable to our setting. So in conclusion, these are some of the preliminary results. Still have to do some data management and completion of data analysis. But I am hoping that this is a stepping stone to bigger things, particularly encouraging research in this area in low to middle income countries. And paying particular cognizance of the instruments in terms of validation, translation, cultural sensitivity, and looking at qualitative research, because we know there's a lot of richness that comes out of that. These are my references, and I'd just like to end with a Bantu proverb that says, Umuntu gumuntu gabantu, which says, basically, I am because you are. I am a person because of other persons. And this lends itself to two things. So even though we have such disparities between the global north and global south, and even though we may be healthcare workers and then our patients, we're all human at the end of the day. Thank you so much.